Welcome to Enormous Nephrology. This is the Hypertension Series. The Hypertension Series is a series of talks that I delivered during the meetings of the Hypertension Task Force at Stroger Hospital of Cook County. All my talks, whether they're on hypertension or any other nephrology topic of interest, will be housed at youtube.com/@irfanmoindeen-kidney. This current talk is a review of the MDRD trial, and we will try to determine what were the significant findings of the MDRD trial, what were the drawbacks, what were the strengths, what can we use the MDRD trial to conclude about hypertension, about what we can do for the patient with hypertension in terms of hypertension goals, cardiovascular goals, and goals with respect to chronic kidney disease. Treatment of hypertension can decrease the incidence of cardiovascular and cerebrovascular disease. Likewise, it has long been speculated that reducing elevated blood pressure will slow the rate of progression of chronic renal disease. The MDRD study, the modification of diet in renal disease, was a multi-center randomized clinical trial conducted from January 1989 to January 1993 to determine the effect of dietary protein restriction and strict blood pressure control on the progression of renal disease. The primary outcome measure was the rate of change in the glomerular filtration rate, the SLOPE. 2,507 persons were screened, and they went through 3 baseline visits, and ultimately, after exclusion, 840 participants were randomized. There were 2 blood pressure groups, the usual blood pressure group and the low blood pressure goal group. The usual blood pressure goal was a MAP of less than 107 millimeters of mercury in persons aged 18 to 60 years of age. And in persons aged greater than 61 years, the MAP goal was less than 113. In the low blood pressure goal group, the MAP goal was less than 92 millimeters of mercury, and then less than 98 millimeters of mercury if the patient was aged greater than 61 years. Patients were enrolled in Study 1 or Study 2 based on their GFR. Study 1 included patients with GFR between 25 to 55 milliliters per minute per body surface area, and Study 2 patients had GFRs between 13 to 24 milliliters per minute per body surface area. And then in Study 1, patients were either in the usual protein category or the low protein category. And in Study 2, they were either in the low protein category or the very low protein category. About 585 patients were enrolled in Study 1, and 255 patients were in Study 2, and they were approximately equally divided between the usual and low blood pressure groups in both Study 1 and Study 2. The inclusion criteria for MDRD was that the age should be between 18 to 70 years. Study 1, as I said, was between GFR of 25 to 55 milliliters per minute per body surface area. Study 2, if the GFR was between 13 to 24 milliliters per minute per body surface area. The MAP had to be less than 125 millimeters of mercury, so patients did not have to be hypertensive to be included in this study. The exclusion criteria included pregnancy, body weight under 80% or over 160% of ideal body weight, diabetes mellitus requiring insulin therapy, urinary protein excretion exceeding 10 grams per day, history of renal transplantation, and if there was doubts about compliance. The study began with a 3-month baseline period in which blood pressure, creatinine clearance, and urine protein to creatinine ratio were measured initially and then every month for a total of 4 months. For randomization, patients were stratified according to the clinical center and the average baseline blood pressure and according to the rate of change in the serum creatinine during the screening period. After randomization, patients were instructed to modify their intake of protein and phosphorus to achieve the goals of the diet to which they had been assigned. Dietary sodium was not restricted. The recommended antihypertensive regimen was an ACE inhibitor with or without a diuretic, calcium channel blocker, and other medications as needed were added on. Blood pressure was measured monthly. Adjustments in therapy were made monthly or more often. GFR was measured at 2 months, at 4 months, and every 4 months thereafter on the basis of the renal clearance of iodine 125 iothalamate. These are the baseline characteristics of the MDRD study. In study 1, the mean GFR was around 38 milliliters per minute per body surface area. Serum creatinine was 1.9 to 2 milligram per deciliter. Mean systolic blood pressure was in the 130s. Mean diastolic blood pressure 80s. And the mean MAP was 97 to 98 millimeters of mercury. In study 2, the mean GFR was around 18 milliliters per minute per body surface area. Mean serum creatinine was 3.2 to 3.5 milligram per deciliter. Mean systolic blood pressure was 130s. Mean diastolic blood pressure was 80s. And mean MAP was 97 to 99 millimeters of mercury. As you can see, the MAPs were relatively well separated in the two groups, the usual group versus the low blood pressure group, as well as in study 2. The MAPs were relatively well separated. Here we're going to look at systolic blood pressure and diastolic blood pressure. The vertical lines show the 25th and 75th percentile. So you can see that even though the means seem to be somewhat separated, there was actually quite a bit of overlap. And as you can see, the vertical lines will show you the 25th and 75th percentile. So there was quite a bit of overlap in the systolic blood pressures and in the diastolic blood pressures, even though the maps were somewhat separated. But then we'll also discuss that the target map difference and the achieved map difference were actually quite different. Here are the results. As you can see, the initial 4 months actually saw a decline in GFR, both in the low blood pressure group and in the low protein group. But over the first year, there was improvement in GFR in the low blood pressure group as well as in the low protein group. But if you were to project over the next 3 years, there was actually no significant difference between the diet groups or the blood pressure groups. The same is true of study 2. The average decline in GFR did not differ significantly between the two diet groups or between the two blood pressure groups. However, we will see in the next few slides, there was significant interaction between baseline urinary protein excretion and blood pressure interventions. This is just a graphic representation of the same thing. The GFR decline was not significant between the usual blood pressure group and the low blood pressure group. Similarly, the rate of ESRD or death between the usual blood pressure group and the low blood pressure group in study 2 was not statistically significant. The benefit of low blood pressure, however, was greatest in the 54 patients with urine protein excretion that exceeded 3 grams per day at baseline. The benefit was moderate in 104 patients with urine protein excretion about 1 to 3 grams per day. And there was no benefit in the 420 patients with urinary protein excretion under 1 gram per day. This is a graphic representation of that. This is urinary protein excretion less than 1 gram per day, and the mean rate of GFR decline is similar. Above 3 grams per day, the mean GFR decline is much greater in the usual blood pressure group than the low blood pressure group. And this is moderately true in urine protein to creatinine excretion between 1 to 3 grams per day. The same is true of study 2. If the urine protein to creatinine excretion was less than 1 gram per day, the mean GFR decline was similar. Greater than 3 grams per day, the mean GFR decline was much steeper in the usual blood pressure group, and the difference was not so stark in the urine protein to creatinine excretion of 1 to 3 grams per day. The 53 Black patients had a more rapid projected mean decline in GFR than the other 525 patients. This was 19 milliliters per minute per body surface area versus 11 milliliters per minute per body surface area. And the projected GFR decline in the Black low blood pressure group was half that in the Black usual blood pressure group, 14 versus 25 milliliters per minute per body surface area. This is another analysis of continuous variables, dichotomous variables, as well as diagnoses of polycystic kidney disease versus glomerular disease. Here, a minus sign indicates a faster GFR decline as the baseline covariate increases, while a plus sign indicates a slower GFR decline as the covariate increases. The two baseline factors that most strongly predict the rate of progression are baseline proteinuria and a diagnosis of polycystic kidney disease. And here you can see that proteinuria has the most negative coefficient of negative 1.04. In terms of dichotomous variables, history of hypertension was important, Black race was important, and prior progression was also important, as was history of smoking. And then, of course, polycystic kidney disease had a strong correlation with rate of progression. This is another graphic representation of the correlation between baseline proteinuria and GFR slope. This is the usual blood pressure, and you can see here that as proteinuria exceeds a certain amount, the rate of GFR decline is much steeper. And this is in the usual blood pressure group. And in the low blood pressure group, that GFR decline is not as steep. So what conclusions were drawn from the MDRD trial? The MDRD study reported at that time that a blood pressure goal lower than usually recommended for the prevention of cardiovascular disease significantly slowed the progression of chronic renal disease in patients with proteinuria. On the basis of these results, a blood pressure goal of MAP less than 92 millimeters of mercury was recommended. This was equivalent to about less than 125 over 75 millimeters of mercury. This was in patients with urinary protein excretion of greater than 1 gram per day. And a similar trend was observed in Blacks, but the data were not conclusive enough for a definitive recommendation. As far as an analysis of the MDRD trial, the first thing to note is that the target MAP difference between the low blood pressure and the usual blood pressure groups was 15 millimeters of mercury. The actual mean MAP difference that was achieved was only 4.7 millimeters of mercury. But in defense of that, though there was significant overlap in MAPs, systolic blood pressures and diastolic blood pressures, throughout the course of this study, the mean difference was actually similar to hypertension studies, showing cardiovascular benefit to lower blood pressure targets. So the MDRD study was not much different from other hypertension studies which had already shown cardiovascular benefit. The SPRINT trial and the ACCORD trial, as we discussed, established a systolic blood pressure target of 120 versus 140 millimeters of mercury. So those were landmark trials in terms of studying blood pressure targets. What were the reasons for the limited difference between blood pressure groups? Some patients in the usual blood pressure group were prescribed a lower blood pressure than the study design. And some patients in the lower blood pressure group were actually prescribed a higher blood pressure than the study design. And then there was use of antihypertensive medications for conditions other than hypertension. And in some cases, there was inability to lower blood pressures due to symptoms such as feeling faint. However, the low blood pressure target was achievable in the majority of patients with chronic kidney disease, up to 62%. And we'll discuss the safety profile and the adverse reactions in subsequent slides. There were no significant differences between blood pressure groups in the incidences of deaths, hospitalizations from cardiovascular or cerebrovascular disease, or stop points resulting from serious medical complications. The lower achieved systolic blood pressure actually correlated with a decreased risk of hospitalization from cardiovascular or cerebrovascular disease, as you can see in study A, where the p-value was significant in terms of all first hospitalizations or first cardiovascular or cerebrovascular hospitalization. And then also, if you combined both studies, this was mainly in the systolic blood pressure group. And then in study B, this was only true for the first cardiovascular or cerebrovascular hospitalization when studied according to systolic blood pressure. So the first thing is that the MDRD study was not designed to investigate the effect of lowering blood pressure on cardiovascular or cerebrovascular events and had limited power to detect such effects. This was a chronic kidney disease study. Second, the primary ICD diagnosis code for 12 of the 50 initial hospitalizations might not have been accurate. Third, not all patients in the MDRD study had hypertension. Fourth, few patients had a history of cardiovascular or cerebrovascular disease at the time of entry. Thus, these conclusions are most applicable to patients with chronic renal disease without these comorbid conditions. What are the strengths of the MDRD study? The study randomized participants to different blood pressure goals, strengthening the evidence base for causality between blood pressure control and chronic kidney disease progression. The MDRD study explored the effects of blood pressure control in patients with varying levels of proteinuria. This revealed that the lower blood pressure targets were more beneficial in patients with higher proteinuria. Extended follow-up of MDRD participants, including data linkage to ESRD and mortality registries, provided valuable insights into the long-term impact of blood pressure control strategies. The MDRD study included patients with both moderate and severe renal insufficiency. What were the flaws of the MDRD study? A significant weakness was the low recruitment of minority patients. 85% of the participants were white. The initial analysis did not find a significant difference in the overall rate of GFR decline between blood pressure groups. The study might have been underpowered to detect a significant effect in the overall population, particularly for the primary outcome. Though the target MAP difference was about 15 millimeters of mercury, the achieved mean MAP difference was only 4.7 millimeters of mercury. MDRD was powered for kidney events and underpowered for cardiovascular events. The MDRD study included patients with low cardiovascular risk. This selection bias prevents one from applying the results of the MDRD study to patients with higher cardiovascular risk. MDRD and ASK used mean arterial pressures, MAP targets of less than 92 versus less than 107 millimeters of mercury. Less than 92 millimeters of mercury could be 125 over 75, 140 over 68, 160 over 58, etc. And 107 millimeters of mercury could be 140 over 90 or 125 over 98. So MAP targets may not be as meaningful as specific systolic blood pressure targets. As we discussed, the systolic blood pressure targets of 120 versus 140 millimeters of mercury were specifically used in the SPRINT and ACCORD trials. In summary, intensive MAP lowering to less than 92 millimeters of mercury reduces progression of chronic kidney disease as well as the risk of cardiovascular events and all-cause mortality. Intensive MAP lowering is generally safe. And MDRD and ASK provide evidence for renoprotective effects of intensive blood pressure lowering. However, the evidence is of low quality. In the next volume of this series, we'll do a review of the ASK trial, discuss its strengths and weaknesses, discuss how it contributed to the establishment of blood pressure goals, and then we'll combine ASK with the MDRD data to assess kidney and cardiovascular outcomes, and then we'll discuss what remains unknown or uncertain. The couplet of this month is by Rumi. Dance when you're broken open. Dance if you've torn the bandage off. Dance in the middle of the fighting. Dance in your blood. Dance when you're perfectly free. Again, all of my talks are available at youtube.com/@irfanmoinuddin-kidney. Thanks for listening. See you next time.